Welcome back to the Deep Dive. We're the show that takes these big, complex topics and, well, we try to boil them down to the insights you actually need.
That's the goal.
Today we're getting into something truly remarkable, one of your body's hardest working organs, but one we probably don't think about enough, the liver.
Absolutely. It's like this internal powerhouse, constantly filtering, detoxifying, doing hundreds of vital jobs just to keep things running.
But what happens when that powerhouse, that silent workhorse, comes under attack? When it gets inflamed, damaged, sometimes by an enemy you can't even see?
Well, that's exactly what we're diving into today. We're talking about hepatitis.
Hepatitis, okay.
And, at its very core, hepatitis just means inflammation of the liver. Simple definition. But as we're about to find out, it's way more complicated than just one single condition.
Right.
So our mission today is to really unpack what hepatitis virus means, because it's not just one thing. It's actually a whole family of different viruses, and each one has its own story, its own way of operating.
Okay, so we'll look at the different types, how they work inside your body, how they travel.
Exactly. Trace their journeys, which can often be silent, and crucially, connect all this back to, your personal health, and also specifically what it means for certain professions like dentistry, which is a big focus in our source material today.
Okay, so we've got some specific angles. What sources are we using?
You've got two really detailed ones. First, a set of medical slides titled DO4 Hepatitis Virus. These really lay down the sort of foundational science, the virology, the pathology.
Got it. The nuts and bolts.
Pretty much. And second, we have this really illuminating paper called Hepatitis and its Dental Implications. And that one zooms right in on the practical side, how these viruses affect dental care, day-to-day practice.
Excellent. So a really comprehensive look at something that affects millions of people all over the world. Let's get started.
Let's do it.
Okay, so let's unpack this term hepatitis. When people just say hepatitis, what are we actually talking about? Is it just like a general liver issue or something more specific?
Well, thinking liver issue is definitely the right starting point. Fundamentally, it is a broad medical term. It just means inflammation of the liver. That's it.
Okay.
But it's so important to understand why that inflammation matters so much. Your liver is absolutely central to your overall health, right? It does everything from detoxifying stuff, metabolizing nutrients, making essential proteins, storing energy. The list goes on.
So when it gets inflamed.
Exactly. When it gets inflamed, all those critical functions get compromised. And that can lead to this whole cascade of potential health problems that affect your entire system, not just the liver itself.
So it's definitely not just one disease with one cause then, because you often hear people link it straight to viruses.
Yeah, that's a really common association and a great point to clear up right away. While viral hepatitis is a huge focus, and for very good reasons, as we'll get into, it's actually just one category, hepatitis can come from a whole range of different things. Well, besides viruses, you can have bacterial hepatitis, actual bacteria infecting the liver. Then there's toxic and drug-induced hepatitis. Certain chemicals, maybe industrial solvents, even some common medications can damage the liver.
Right, like acetaminophen overdose, maybe?
That's a classic example, yeah.
Yeah.
Then, of course, there's alcoholic hepatitis from drinking too much alcohol over time. And interestingly, you can even have autoimmune hepatitis.
Autoimmune, so the body attacks itself.
Precisely. Your own immune system mistakenly targets and attacks your liver cells. It's fascinating, but also obviously quite serious.
Wow, okay. That's a much bigger picture than I think most people have in mind. But it sounds like our sources really zero in on the viral types. Why is that?
Absolutely. While it's good to know about all those causes, viral hepatitis is, without a doubt, a massive public health concern. Our sources mention this really striking figure, an estimated 10 million cases worldwide.
10 million? That's huge.
It's enormous. Think about the entire population of, say, Sweden. That many people dealing with this, often silently. And when we talk viral hepatitis, we're mainly looking at 5 specific, unrelated viruses that are hepatotropic.
Hepatotropic meaning?
Meaning they have specific liking, a sort of laser focus, for your liver cells. These are the big 5. Hepatitis A, B, C, D, and E.
A, B, C, D, E. Got it.
Now, there are other less common viruses that can cause liver problems too. Things like CMV, herpes virus, rubella, Epstein-Barr virus.
Yeah.
But those big 5 are the main players we really need to understand.
Okay. So once one of these 5 viruses gets into the liver, they don't all act the same way, do they? They can lead down different paths, different stages of infection.
Exactly right. These different hepatotropic viruses can result in a whole range of clinical patterns, different pathological outcomes, and we can actually categorize these into distinct stages of infection. Understanding these stages is, well, it's really key to grasping the whole spectrum of hepatitis from something that's just a brief illness to something that could be a lifelong battle.
Okay, let's break down those stages. There's one that sounds particularly worrying from a public health angle, the carrier state. What does that actually mean for someone and for, the community?
Right, the carrier state. This refers to someone who has the infection, they're harboring the virus, but they're asymptomatic. They show no symptoms themselves.
But they can still spread it.
That's the crucial part. They can still transmit the infection to other people. And here's a really fascinating, super important distinction. Hepatitis A and hepatitis E are unique because they do not produce a carrier state.
Oh, interesting. So A and E, you either get sick and recover, or you don't become a long-term carrier.
Exactly. With A or E, you generally recover fully, develop immunity, or in very, very rare cases, you might get that severe fulminant disease, but you don't become this long-term asymptomatic source of infection. Hepatitis B, though, that's a whole different ballgame.
Yeah.
HBV is responsible for the largest number of carriers in the world. It's a massive global health challenge, precisely because so many people carrying it have no idea, making transmission control incredibly difficult.
That's a huge difference. So if someone is asymptomatic, are they automatically a carrier? Or is there a distinction between carrier state and just asymptomatic infection?
Good question. There's a subtle difference. Asymptomatic infection just means the virus is there, but the person isn't showing symptoms. These cases often get picked up by chance, maybe during a routine blood test that shows high liver enzymes, those serum transaminases, or maybe just by finding antibodies.
Okay.
The carrier state is a specific type of persistent asymptomatic infection where the person can transmit the virus for a really long time, sometimes even for life, like with hepatitis B. So an asymptomatic infection might be a carrier state, but not all asymptomatic infections are long-term carriers. Does that make sense?
Yeah, it does. Okay. So then we get to the stage most people probably think of, acute hepatitis. What defines this stage? What does it generally look like?
Right, acute hepatitis. This is basically the viral infection kicking off rapidly, usually within hours, days, or maybe a few weeks. It's generally defined as lasting less than 6 months.
And during that time?
Well, during this acute phase, the infection can either resolve on its own, which happens often with some types, or, and this is the more worrying path, it can progress to chronic hepatitis, which has much more serious long-term consequences.
Okay.
But the most common thing you see with all these hepatotropic viruses is this initial acute inflammation involving the whole liver. And interestingly, Hep A, B, C, D, and E generally follow a pretty similar clinical course during this acute phase.
And within that acute phase, you mentioned stages too, like a sort of unfolding drama.
That's a great way to put it. Yeah, you can think of it as a 4-act play. Act 1 is the incubation period. This is the sneaky phase. It's the time between when you're first exposed to the virus and when symptoms finally show up.
So you feel fine.
Completely fine. Asymptomatic. But, and this is absolutely critical for public health, your infectivity, your ability to spread it, is often highest during the last few days of this incubation period, before you even know you're sick.
Wow. Silent spreading.
Exactly. And the length of this period varies a lot between the different viruses. Could be weeks, could be months.
Okay, so a silent threat indeed. What happens after that symptom-free start? What's Act 2?
Act 2 is the preicteric phase. This is when your body starts sending out the first general alarm signals. It's marked by what we call prodromal constitutional symptoms.
Prodromal constitutional, meaning?
Meaning general, non-specific feelings of being unwell that pop up before the more classic symptoms like jaundice appear. Think flu-like symptoms. Maybe vomiting, nausea, just feeling generally lousy, maybe a fever.
Okay, vague stuff.
Right. And this is also when we start seeing the first lab evidence of liver cell injury through those biochemical tests we talked about. We look for rising levels of serum total, bilirubin, alkaline phosphatase, and especially those key liver enzymes. ALT, alanine aminotransferase, and AST, aspartate aminotransferase.
The ones that leak out of damaged liver cells.
Precisely. Finding high levels of ALT and AST in the blood is like finding bricks on the lawn, a clear sign something's wrong with the house, the liver in this case.
Got it. And then comes Act 3, the one everyone recognizes.
Yeah.
The yellowing, the jaundice. That's the icteric phase.
Yeah, exactly. The icteric phase kicks off with the unmistakable arrival of clinical jaundice, that yellow tint to the skin and the whites of the eyes. And interestingly, as the jaundice appears, those general constitutional symptoms from the pre-icteric phase often start to fade a bit.
What else happens in this phase?
Well, other classic features include dark-colored urine, That's due to bilirubin spilling into the urine and pale or clay-colored stools because less bile is getting produced or released. People often lose their appetite, lose weight, and might have abdominal discomfort because their liver is enlarged and tender. This whole ecteric phase typically lasts about 1 to 4 weeks.
And finally, Act 4, recovery.
Hopefully. That's the post-ecteric phase. This follows the jaundice period. Clinical symptoms improve, and those biochemical markers, the liver enzymes, start heading back towards normal. Recovery usually happens within 2 to 12 weeks.
Usually.
Well, it's important to note that the recovery can often be more prolonged, take longer, with hepatitis B and hepatitis C infections, which kind of hints at their greater potential for causing long-term trouble and sticking around.
Right. And speaking of long-term, what if the body doesn't clear the virus? If that acute phase just lingers, that gets us to chronic hepatitis, doesn't it?
Yes, and that's where the real danger often lies, especially for certain types of hepatitis. Chronic hepatitis is a significant, often very serious stage. The official definition is hepatic disease, liver disease, that continues or keeps relapsing for more than 6 months.
And which viruses cause this most often?
The vast majority of chronic hepatitis cases come from infection with hepatitis B, hepatitis C, and also combined infections of hepatitis B and D. And this chronic state, this ongoing inflammation, it carries really severe long-term risks for your liver.
Such as
Progression to scarring of the liver, that's cirrhosis. This scarring is irreversible, and it can ultimately lead to liver failure. It also significantly increases your risk of developing liver cancer. This is exactly why catching and managing these specific types early is so incredibly important.
And then there's the really severe but thankfully rare outcome, fulminant hepatitis. That sounds terrifyingly fast.
It is. Fulminant hepatitis is rare, thank goodness, but it's a devastating syndrome. It's characterized by rapid, usually just days or weeks, massive necrosis, meaning tissue death of the liver parenchyma, the functional tissue of the liver. And the liver actually shrinks, sometimes called acute yellow atrophy.
Just rapid liver death.
Essentially, yes. It typically happens after infection with certain hepatitis viruses. And while it's rare, when it does occur, it's a critical, life-threatening emergency needing immediate intensive medical care. There are even 2 patterns: submassive necrosis, which is a bit slower, maybe developing over up to 3 months, and massive necrosis, where liver failure is incredibly rapid, occurring within just 2 to 3 weeks.
Okay, so we've got the general stages mapped out, from the stealthy start to the potential chronic fight. Now let's dive into the details of these major viral players. Our sources break them down nicely, and it looks like grouping them by how they spread the transmission routes makes a lot of sense. We can start with the one spread through the fecal-oral route.
That's a really logical way to approach them, yeah. And first up in that group is hepatitis A, or HAV. Our sources call it the transient invader.
Transient invader. Sounds like it doesn't plan on staying long, which is good news. What's its structure like, and why does that matter?
Right, transient is key. HAV is a tiny virus, about 27 nanometers. It's non-enveloped, meaning it doesn't have that outer fatty layer, and it's a single-stranded RNA virus. It belongs to the Picornaviridae family.
And that non-enveloped part is important.
Hugely important. That naked capsid makes it incredibly tough. It's much more stable than other related viruses when exposed to things like acid, heat, and other harsh conditions. It can actually resist boiling at 100 degrees C for 5 minutes and stomach acid.
Wow. Hardy little thing.
Very. That's why it survives so well in contaminated food and water. It is susceptible to UV light and standard chlorine treatment, though, which is good for water purification. And importantly, there's only one serotype of HAV known, which makes vaccine development much simpler.
So its tough structure is key to how it spreads. How does it actually get in and cause disease?
Precisely. Its pathogenesis is totally linked to that resilience. It spreads primarily via the fecal-oral route, basically, through ingesting contaminated food or water. Usually that means a breakdown in sanitation or hygiene somewhere along the line.
Okay.
The virus first replicates in your gut, your gastrointestinal tract. Then it travels to the liver through the bloodstream, that's called hematogenous spread, and infects the liver cells, the hepatocytes. Now, how exactly it damages those cells isn't perfectly understood, but the current thinking is that it's mostly your own immune cells, specifically cytotoxic T cells, that cause the main damage as they try to clear out the infected liver cells.
So, like HBV, it's the immune response doing the damage.
It seems that way, yes.
Yeah.
But crucially with HAV, once the infection is cleared, that's it. No chronic infection happens, and there's no carrier state associated with hepatitis A. You clear it, you're immune. The virus does start appearing in feces about a week after infection, often before symptoms show up, which helps it spread.
Okay, so generally acute, self-limiting, which is reassuring. Where do we see it most often, and what do the symptoms typically look like?
It's much more common in tropical and subtropical areas, particularly in developing countries. And that's largely down to issues with sanitation and hygiene practices that just make it easier for the virus to spread. Clinically, it often starts with those general prodromal symptoms we talked about: vomiting, nausea, fever.
Right.
Some cases might progress to an enlarged liver, hepatomegaly, jaundice, dark urine. But for most people, especially kids and young adults, it's usually pretty mild. It resolves on its own, and importantly, it gives you lifelong immunity afterward. The incubation period is typically 2 to 6 weeks.
How do doctors actually confirm it's Hep A? Is it straightforward?
Yeah. Diagnosis is usually quite straightforward. It's primarily done by detecting the HAV antigen in feces during the acute illness, or, much more commonly, by finding specific antibodies in your blood serum. Specifically, IgM class anti-HAV antibodies.
IgM means recent infection.
Exactly. IgM antibodies are the body's first responders, so finding them means you have an active or very recent infection. Later on, IgG anti-HAV antibodies appear, and they stick around long term, indicating you've either had it in the past and recovered, or you've been successfully vaccinated. We can also use biochemical tests, checking bilirubin, protein, ALT levels, and sometimes look for HAV RNA in the stool as supporting evidence.
And treatment. Is there a specific drug for Hep A, or is it just about writing it out?
Unfortunately, no specific antiviral therapy exists for HAV infection. Treatment is really just supportive care. Adequate bed rest, a good nutritious diet to help the liver heal. If someone has anorexia, lots of appetite, maybe small frequent meals, or even IV fluids with glucose if needed, just to keep their strength up.
But most people recover fully.
Yes. The really good news is most people recover completely without any long-term issues, which means prevention is absolutely key here. We have excellent formalin inactivated HAV vaccines that are highly effective. There's also passive immunization with immune serum globulin for short-term protection. And of course, the basics. Good personal hygiene, thorough hand washing, and ensuring safe drinking water supplies are crucial public health measures.
What about in the dental office? Given how it spreads, I wouldn't think it's a major risk for dentists, right?
You're absolutely right. HAV is not considered a significant infection risk in dentistry because it's fecal-oral, not primarily bloodborne or respiratory. While theoretically, some virus particles might be in saliva, transmission that way is considered rare. Needle stick transmission has only been reported occasionally.
So standard precautions are enough.
Pretty much. For dental teams, standard infection control measures, gloves, masks, proper instrument sterilization are generally perfectly adequate to prevent any spread. It's one less major worry compared to some other viruses we'll discuss.
Okay, good to know. Now let's talk about its cousin, hepatitis E or HEV. Similar transmission, similar characteristics.
Very much so, hence the cousin comparison. HEV is also a non-enveloped ssRNA virus belonging to the Hepaviridae family. Like HAV, only one serotype is known. Pathologically, it usually follows a pretty benign course, similar to hepatitis A with a low mortality rate, generally around 1 to 2%.
Usually benign, but sometimes not.
Well, while it's typically self-limiting, fulminant hepatitis, that really severe rapid liver failure, is infrequently but definitely associated with HEV, so it can be very serious in rare cases.
And it spreads the same way, primarily waterborne.
Precisely. Transmission is fecal-oral, mainly through drinking contaminated water.
Right.
This is especially common during rainy seasons or in areas with poor sanitation infrastructure.
Mm-hmm.
Spreading within families or through blood is rare. Outbreaks are common in places like Africa, Asia, and Latin America, particularly where sewage disposal isn't adequate. It's actually the main cause of what we call enterically transmitted non-A, non-B hepatitis in many parts of the world.
Okay. And clinically, how does it look compared to Hep A? Any key differences we need to know about?
Clinically, it looks a lot like hepatitis A. The incubation period is around 40 days, a bit longer than HAV's average. It's usually self-limiting and resolves within 4 to 6 weeks. And this is the really crucial distinction. The thing that makes HEV stand out is more severe in pregnant women, especially in their third trimester.
Wow. Okay. That's a huge red flag.
It really is. For some reason, HEV hits pregnant women much harder, particularly late in pregnancy. Mortality rates can jump dramatically in this group, making it a major concern in areas where HEV is common.
That's critical information. How is HEV diagnosed, and what about treatment and prevention, especially given that risk for pregnant women?
Diagnosis uses tests like Western blot or ELISA, to detect IgM and IgG anti-HEV antibodies. IgM shows up first during recent infection, then fades, while Ig sticks around longer, indicating past exposure. PCR assays can also find HEV RNA in serum or stool, and like other types, liver enzyme tests, ALT, bilirubin, protein, will show inflammation.
And treatment. Is there a vaccine?
Treatment, like HEV, is mainly supportive, rest, nutrition. Here's the challenge. Currently, there's no specific vaccine or immunoglobulin available for HEV on a widespread global scale. A vaccine has been developed and approved in China, but it's not universally available yet. So prevention really hinges on improving sanitation and ensuring access to clean drinking water, especially in those high-risk regions and for vulnerable populations like pregnant women.
And for dental teams, same story as HAV, low risk.
That's right. Because it's fecal-oral, HEV is considered highly unlikely to be transmitted in dentistry. Standard infection control practices are more than enough to handle it.
Okay, that covers the fecal-oral group. Now let's shift gears to group 2, the parenterally transmitted viruses. These often seem like a much bigger, more chronic threat. First up is hepatitis B, HBV. You called it the global silent threat. Its structure sounds way more complex than A or E.
Oh, it definitely is. HBV is an enveloped dsDNA virus. That's double-stranded DNA, unlike the RNA viruses we just discussed. It belongs to the Hepataviridae family. The complete infectious virus particle is called the Dane particle, a sphere about 42 nanometers across.
Okay, the Dane particle.
But what's really fascinating is that in an infected person's blood serum, you also find these other non-infective particles, smaller spheres, and also tube-shaped structures. These are basically just excess bits of the virus's envelope protein, known as hepatitis B surface antigen, or HBsAg.
So HBsAg is like the virus's outer coat, and the body makes tons of extra coats that aren't even part of a full virus.
Exactly. Think of HBsAg as the virus's signature protein, and it's produced in massive quantities, coating these non-infectious decoys as well as the real virus. It's a key marker we look for in testing.
Makes sense. So what's inside the actual infectious Dane particle?
Inside the core, you've got its circular, partially double-stranded DNA genome. You also find a DNA polymerase enzyme, which surprisingly has reverse transcriptase activity, something we usually associate with retroviruses like HIV. And there's the core antigen, HBsAg.
Okay, core antigen. And there's an E antigen, too.
Right, hepatitis B E antigen, HBAg. It's actually a breakdown product of the core antigen. Finding HBAg in the blood is really important because it signals active infection and higher infectivity. It's like the virus is actively replicating and very contagious. Conversely, if someone develops anti-HB, the antibody against HBAg, it generally means reduced infectivity.
So HBAg is bad news, anti-HB is better news.
Generally speaking, yes. And the surface antigen, HBsAg, is itself antigenically complex. It has different subtypes based on variations in its protein structure, which contributes to why HBV is so widespread globally and can be persistent.
Okay, quite intricate. Now, how does this complex virus actually damage the liver? Does it directly kill the cells like some viruses do?
This is one of the most interesting things about HBV, and it surprises a lot of people. HBV has a very specific preference, or tropism, for replicating in liver cells. It gets into the bloodstream, finds hepatocytes, and infects them. But, and here's the crucial part, that the actual liver injury, the cell damage, is primarily caused by the host's own immune response.
Wait, our own immune system causes the damage, not the virus itself.
Largely, yes. It's your cytotoxic T cells recognizing the viral proteins on the surface of infected liver cells and attacking those cells to try and eliminate the infection. The virus itself isn't directly cytopathic, meaning it doesn't inherently destroy the cell it infects. It's the immune system's battle against the virus that leads to most of the liver inflammation and damage.
That's counterintuitive. It makes treating it sound complicated if you're fighting the patient's own response.
It definitely adds layers of complexity. And sometimes the formation of these antigen-antibody complexes as the immune system fights the virus can cause symptoms outside the liver too, things like joint pain, arthralgia, arthritis, and even chronic issues like kidney problems, glomerulonephritis, cryoglobulinemia, or vasculitis.
And this battle can lead to the chronic carrier state.
Yes. If the immune system can't fully clear the infection, it can lead to persistent infection of the liver cells, resulting in that chronic carrier state where HBsAg stays detectable in the blood for at least 6 months. And here's a critical point for public health. The risk of becoming a chronic carrier is vastly different depending on when you get infected. If infection happens in newborns, the risk is incredibly high, about 90%.
90% for newborns.
Yes. Whereas if an adult gets infected, the risk of becoming a chronic carrier is much lower, around 5%. That massive 90% risk in newborns is why preventing mother-to-child transmission is such a huge focus. It means a very high chance of lifelong infection if it's not caught and managed right at birth.
Yeah. 90%. Wow. Where is HPV most common and how does it spread, making it this silent global threat?
It's found worldwide, but prevalence is much higher in parts of Africa and Asia. Transmission is primarily parenteral, basically, through contact with infected blood or body fluids.
So, needles, transfusions?
Yes, sharing contaminated needles among IV drug users, unsafe medical or dental procedures with unsterilized equipment, unscreened blood transfusions, though that's much rarer now in developed countries. But also, importantly, through sexual contact, and as we just discussed, perinatal transmission from mother to baby during childbirth.
Okay.
In developed nations, high-risk groups tend to be injecting drug users, men who have sex with men with multiple partners, people migrating from high-prevalence areas, and significantly healthcare workers, including dental personnel, due to potential occupational exposure.
And it's very infectious.
Extremely infectious. Even tiny, invisible amounts of infected blood or body fluids can transmit it. It's present in various fluids, but the highest concentration is in blood and also in mixed saliva, especially when there's gum disease, because of serum exudate leaking from the gingival sulcus.
The gingival sulcus, that space between the tooth and gum, that makes it super relevant for dentistry.
Absolutely. Any procedure that causes even minor bleeding in the mouth poses a potential risk if the patient is HPV positive and precautions aren't strictly followed.
Okay. What are the typical clinical signs of an HPV infection? Does it always cause symptoms?
Well, the incubation period is quite long, anywhere from 30 to 180 days, so it can be brewing for a while. Often the initial pre-icteric symptoms are pretty nonspecific, like nausea, feeling weak, maybe vomiting. Many infections, especially in adults, might even be asymptomatic or very mild.
And then the risk of becoming chronic.
As we said, about 5% of infected adults become chronic carriers. And for those chronic carriers, especially if they remain HBag positive, indicating ongoing viral replication, there's a significantly higher long-term risk of developing hepatocellular carcinoma liver cancer. That's the real long-term danger.
Given all this complexity, acute versus chronic, carriers, different antigens, how do doctors figure out what's going on? Diagnosing HPV sounds like solving a puzzle with all those markers.
It really is like solving a puzzle. Serological testing for different viral markers is absolutely key, and each marker tells part of the story.
Okay, break it down for us. HBsAg.
HBsAg, the surface antigen. If this is present in your blood, it means you have an active HPV infection and you're potentially infectious. If it stays positive for more than 6 months, that confirms you're a chronic carrier, with all the associated risks of chronic liver disease and cancer.
Okay, surface antigen means active infection. What about HBag?
HBag, the EASE antigen. Finding this indicates active viral replication and high infectivity. If HBag persists for a long time, it suggests a higher likelihood of ongoing liver damage and progression to chronic problems.
So HBag is like a marker of how active and contagious it is. What about antibodies, anti-HBs?
Anti-HB is the antibody to the surface antigen. This is the good one. Its appearance usually signals recovery from infection and immunity against future HPV infection. It's also the marker we look for after successful vaccination. If you have anti-HBs, you're protected.
Excellent. That's the goal of vaccination. What about anti-HBC?
Anti-HBC, the antibody to the core antigen. This one's a bit more nuanced. There are two types. IgM anti-HBC shows up early during an acute or very recent infection. IgG anti-HBC, on the other hand, indicates previous exposure to the virus. It can persist for life. Even after the infection is cleared and HBsAg tag is gone, it's a sensitive marker of ever having been infected.
Okay, so core antibody tells you about exposure past or present. Anything else?
Yes. Beyond these serological markers, we can use molecular methods like PCR to detect HBD DNA itself. PCR is super sensitive and can quantify the amount of virus, which is useful for monitoring treatment response. It can also help diagnose HBV in tricky cases, like someone with liver disease who is somehow HBsAg negative. And of course, monitoring those liver enzyme levels, ALT, AST, and bilirubin, tells us about ongoing liver inflammation.
It's like reading a timeline of the infection through these tests.
Exactly. If you look at those diagnostic charts in textbooks or our sources, you see the patterns HBsAg appearing first, then maybe HBbAg, then IgM anti-HBC, followed later by Ig anti-HBC and eventually anti-HBs as the infection resolves or immunity develops. It paints a very clear picture over time.
That's incredibly detailed.
Yeah.
So how do we treat HBV, and more importantly, how do we prevent it, given its global reach and chronic potential?
For an acute HBV infection, there isn't a specific antiviral cure. Treatment is mainly supportive rest, nutrition, letting the body's immune system fight it off. However, for chronic HBV, we do have treatments. Medications like interferon alpha and nucleotide analogs, drugs like lanivudine, tenofovir, entecavir, can suppress viral replication very effectively.
Do they cure it?
Usually not. They control the virus, reduce liver inflammation, and significantly lower the risk of long-term complications like cirrhosis and liver cancer. But they typically need to be taken long-term, as stopping treatment often leads to the virus rebounding. They manage rather than cure in most cases.
So management, not cure, which makes prevention even more vital.
Absolutely. And the cornerstone, the most effective preventive measure by far, is vaccination. We have highly effective vaccines, both older plasma-derived ones and newer recombinant DNA vaccines using HBsAg. They work incredibly well, achieving over 95% seroconversion, meaning more than 95% of people develop protective anti-HBs antibodies after completing the series.
That's fantastic protection.
It really is.
Yeah.
And a crucial bonus point. Successful HBV vaccination also protects you against hepatitis D infection because HDV absolutely needs HBV to survive. It's a 2-for-1 deal.
Right, we'll get to D later. What about after exposure?
For post-exposure prophylaxis, say, a healthcare worker gets a needle stick from an infected patient. We can use hepatitis B immunoglobulin or HBIG. This provides immediate, temporary, passive immunity. And of course, rigorous screening of all donated blood and blood products is fundamental to preventing transfusion-related transmission.
Now, let's loop back to the dental implications. You mentioned the gingival sulcus, the historical risk. It sounds like HBV was a really serious occupational hazard for dentists.
It absolutely was, historically.
Yeah.
The sources state that HBV infection used to be about 10 times more common among dental healthcare workers, DHCWs, than the general public. Oral surgeons, periodontists, those doing procedures with more blood exposure were at even higher risk.
Were there actual cases of transmission in dental offices?
Yes, sadly. There were documented outbreaks where dentists unknowingly transmitted HBV to their patients. It really highlights the significant risk that existed before current practices were widespread. The virus's presence in the gingival sulcus, combined with procedures that cause bleeding, created a perfect storm for transmission.
But things have changed.
Massively. The game changer was the HBV vaccine. Widespread vaccination programs have significantly reduced this danger. It's probably one of the greatest public health successes in occupational safety for healthcare. That, combined with strict adherence to standard infection control procedures, treating every patient as potentially infectious, using gloves, masks, sterilization, has made HBV transmission in dentistry incredibly rare now.
So vaccination and universal precautions are key.
Essential. And for DHCWs, it's not just getting vaccinated, but also checking their antibody levels afterwards, post-vaccination testing, to ensure they actually developed immunity. It's about protecting themselves and protecting their patients. HBV control in dentistry is a real success story.
A powerful example of prevention working. Okay, let's move on to the next big player, hepatitis C, or HCV. This one's often called the silent epidemic. What makes it so insidious? Why this particular label?
HEV is another enveloped virus, but this one's an RNA virus belonging to the Flaviviridae family, genus Hepativirus. It's about 50-60 nanometers. What makes it so challenging and contributes to that silent epidemic reputation is its incredible genetic diversity.
More diverse than HBV.
Oh, significantly.
Yeah.
There are at least 6 major genotypes and more than 70 subtypes of HCV identified so far. And someone can even be infected with multiple genotypes at the same time. This constant genetic variation makes it extremely difficult for our immune system to get a handle on it and clear it.
Yeah.
It also made it notoriously difficult to grow in lab cultures for a long time, which really hampered research and vaccine development efforts.
So it's constantly changing, making it hard to fight or study. How does it actually cause disease? How does it manage to stick around so persistently, leading to chronic problems unlike Hep A?
HCV has this really unique, almost cunning ability to remain cell-associated and prevent host cell death. Unlike some viruses that replicate quickly and burst out, destroying the cell, HCV tends to set up shop more quietly inside liver cells, hepatocytes, and potentially B lymphocytes, keeping the cells alive while it continues to replicate.
Hiding inside the cells.
Exactly. This strategy is key to its ability to establish persistent infection in the liver. This ongoing presence of the virus in the blood, persistent viremia, leads to chronic inflammation and fibrosis, or scarring, in the liver. And this progresses to chronic hepatitis in approximately 70–85% of infected individuals. That's a huge percentage leading to chronic disease.
70–85% become chronic. That's way higher than HBV in adults.
Much higher. And that chronic state over decades can then lead to severe cirrhosis, liver failure, as a major risk factor for developing hepatocellular carcinoma, liver cancer. The constant presence of these diverse, slightly different virus populations, quasi-species, also helps it evade the immune system over the long term.
The fact that it hides and avoids killing the host cell really explains why it's such a long-term, silent problem. Which brings us to a really critical point our sources touch on. Why has it been so incredibly hard to develop a vaccine for HCV? We did it for HPV. Why not HCV?
That is the million-dollar question, maybe billion-dollar question in Hep C research. It's incredibly frustrating, and there are several major hurdles. First, as we just mentioned, that extraordinary genetic diversity. Trying to create a single vaccine to cover all those genotypes and subtypes is like trying to make one master key for hundreds of slightly different locks. It's immensely complex.
Okay, diversity is one big problem. What else?
Second, HCV is a master at subverting the host immune response. It has mechanisms to actively interfere with or dampen down our immune system right from the start, helping it establish that chronic infection before our defenses can really ramp up effectively. Third, it uses something called epitope masking.
Epitope masking.
Yeah, the virus covers key parts of its surface proteins. The epitopes that our antibodies would normally recognize with sugar molecules, forming a kind of glycan shield. It's like putting on a sugary disguise, so the antibodies can't see or bind to the important parts of the virus. This glycan shield is a major obstacle for vaccine design.
A sugar shield. That's clever from the virus's perspective.
Deviously clever.
Oh.
And finally, a major practical challenge has been the lack of robust in vitro systems and good immunocompetent small animal models. It's just been very hard to study the virus effectively and test potential vaccines outside of expensive and complex primate studies or human trials.
Wow. Diversity, immune evasion, a sugar shield, and research difficulties. That's a formidable set of challenges. No wonder a vaccine has been elusive. How widespread is HCV then globally, and how does it typically spread?
It's a huge global burden. Estimates suggest over 170 million chronic carriers worldwide. That's why it's truly an epidemic, albeit often silent. Transmission is primarily parenteral through blood and blood products.
So similar risks to HPV in that sense.
Very similar high-risk activities. Intravenous drug use is a major driver. Historically, transfusions with unscreened blood were a big source, but screening has dramatically reduced that risk in many countries. Hemodialysis patients are also at risk. Other routes include tattooing, body piercing, even acupuncture if equipment isn't properly sterilized.
What about sexual or mother-to-child transmission?
Those routes occur, but generally less frequently than with HPV. The risk of getting HPV from a needle stick injury, say in a healthcare setting, is estimated somewhere between 0% and 7%. That's lower than the risk for HPV, but still significantly higher than the risk for HIV from a similar injury.
Okay. What about the clinical side of HCV? Are the acute infections usually obvious, or do they fit that silent epidemic pattern?
Mostly silent. Most acute HCV infections are actually asymptomatic or cause only very mild, non-specific symptoms, maybe fatigue or slight nausea. This is a huge part of the problem. People often don't know they've been infected. The incubation period varies widely, from 2 weeks up to 6 months, with an average around 50 days.
And then the chronic phase sets in silently.
Exactly. That vast majority, 80–85%, develop persistent chronic infection. And this chronic phase can simmer away quietly for up to 20 years or even longer before significant liver damage or symptoms finally become apparent. This long latency period is why so many people are diagnosed only when they already have advanced liver disease.
20 years is a long time to be unaware. Our sources also mention possible oral signs.
Yes. Interestingly, there are some reported associations between chronic HCV infection and certain oral conditions. Things like oral lichen planus, that inflammatory condition affecting the mouth lining, potentially some oral malignancies, and maybe salivary gland issues like dry mouth. The exact links and mechanisms aren't fully nailed down, but it's something dentists might observe.
So how do we diagnose HCV? And crucially, what are the treatment options, especially since there's no vaccine? That lack of a vaccine seems like a huge gap.
Diagnosis is mainly done through serology, looking for antibodies to HCV envelope or core proteins using ELISA. These antibodies usually show up about 6 to 8 weeks after infection and typically persist for life in those with chronic infection, even if they later clear the virus with treatment.
So antibodies mean exposure, but not necessarily active virus.
Correct. That's why molecular methods, like PCR assays to detect HCV RNA, are absolutely essential. PCR is highly sensitive, can detect the virus very early, even before antibodies appear, confirms active infection, and is used for genotyping the virus, which helps guide treatment choices. A liver biopsy might still be used sometimes to gauge the extent of liver damage accurately.
And treatment. What can be done for chronic HCV?
This is where the story gets much brighter recently. For many years, the standard treatment was combination therapy with pegylated interferon alpha and ribavirin. It worked for some, but had significant side effects and cure rates weren't always high. But now we have direct-acting antivirals, or DAAs. Yes, these newer drugs, including protease inhibitors and others, directly target specific parts of the HCV replication cycle. They are incredibly effective, often given as simple oral regimens for just 8-12 weeks, with very high cure rates, often over 95%, and far fewer side effects than the old interferon treatments. It's been a true revolution in HCV care.
That's amazing progress. So we can cure it now, even without a vaccine.
We can cure the vast majority of cases. Yes, it's a huge leap forward. But the sources are clear. Currently, no passive or active immunization program for HCV infection is available, and immunoglobulins are not useful. So prevention still relies heavily on screening blood donors, preventing the use of contaminated blood products, organs, or semen, and harm reduction strategies like needle exchange programs to address IV drug use.
So treatment is great, but prevention is still focused on avoiding exposure. What about the dental implications for HCV?
Well, besides those potential oral manifestations a dentist might spot, the main concern is transmission risk. While HCV RNA can be detected in the saliva of some infected people, the sources emphasize there's no unequivocal evidence of HCV transmission as a consequence of dental treatment.
So transmission in the dental chair is unlikely.
Studies looking at dental staff haven't shown a clearly increased risk compared to the general population. The needle stick risk, as we said, is lower than HPV, but higher than HIV. Maybe 3-10% range given in some sources, though the 0.7% was also mentioned. So the bottom line is, while the risk seems lower than HPV, standard infection control measures are essential. Universal precautions protect against HCV, just as they do against HPV.
Makes sense. Okay, let's tackle hepatitis D or HDV. This one sounds really weird. The dependent virus, what's that about?
It is absolutely unique in the virus world. HDV, also called the Delta virus, is tiny, the smallest known animal virus. It's classified as a defective RNA virus, just 35-85 nanometers, with a single-stranded RNA genome. Its defining feature, its total dependence, is that it cannot survive independently. It absolutely requires the presence of hepatitis B virus, HBV, to replicate and spread.
Needs HBV? How does that work?
Think of it like a parasite of a parasite. HDV essentially borrows HBV's HBFAG, that surface antigen we talked about, to use as its own outer coat. Without hijacking HBV's coat protein, HDV can't assemble new infectious particles. The inner core of HDV contains its own unique protein, the delta antigen, HDIG, but it relies entirely on HBV for its packaging and transmission.
So it can only infect you if you also have hepatitis B. How does that play out in terms of illness?
Exactly. You can only get HDV if HBV is present. And this happens in two main scenarios with very different outcomes. First is co-infection. You get infected with both HBV and HCV at the same time. This often results in a more severe acute hepatitis than HBV alone, but it usually resolves, and chronic infection is less common because the immune system often clears both viruses together.
Okay, co-infection might resolve. What's the other scenario?
The second and much more dangerous scenario is superinfection. This is when someone who is already a chronic HBV carrier gets infected with HDV. This frequently leads to chronic delta infection on top of the chronic HBV. And unfortunately, this combination often causes a much more rapid progression to chronic active hepatitis and cirrhosis.
So superinfection is worse.
Much worse, generally. Our sources highlight a really stark statistic. Fulminant liver disease is 10 times more frequent in HDV infection than in HBV infection alone. Having both significantly ramps up the risk of severe, rapid liver failure. The liver damage seems to come from both direct effects of HDV itself and the ongoing immune attack related to the underlying HBV.
10 times the risk of fulminant hepatitis. That's terrifying. Where is HDV found and how does it spread?
Its distribution mirrors HBV prevalence to some extent, with high rates in areas like the Amazon basin, parts of Africa, and the Middle East. Because it depends on HBV, its transmission routes are similar to HBV, mainly parenteral through infected blood. It's a particularly big problem among injecting drug abusers due to needle sharing. Sexual transmission might occur, but seems less efficient than for HBV.
And clinically?
Clinically, symptoms often resemble HBV, maybe more severe in the acute phase. The incubation period is about 2 to 12 weeks, and jaundice is common. As we said, it can cause severe acute hepatitis. Chronic hepatitis is a very common outcome, especially after superinfection, with some studies suggesting up to 70% of those with chronic HDV develop cirrhosis relatively quickly. Its role in causing liver cancer itself is a bit unclear, but given the rapid progression to cirrhosis, it's a major concern.
How do doctors diagnose and treat HDV? Does its dependence on HBV affect the strategy?
Diagnosis involves detecting the delta antigen, HDAg, using ELISA in serum during acute infection, and/or finding antibodies to HDV, delta antibody.
Yeah.
Treatment is tough. HDV infection generally does not respond well to interferon therapy, which has been a mainstay for HBV and HCV. But here's the brilliant part, leveraging its dependency. Since HDV absolutely needs HBV to replicate, successful immunization with the hepatitis B vaccine prevents delta infection.
So the HBV vaccine protects against D2.
Precisely.
Yeah.
If you can't get infected with HBV because you're vaccinated, then HDV has nothing to hijack, and it can infect you. It's a fantastic collateral benefit of HBV vaccination. Avoiding exposure to HDV-contaminated blood is also important, of course, but the HBV vaccine is the ultimate preventive tool.
Another huge win for the HBV vaccine. Okay, and the dental implications would then just follow HBV's lead, right?
Exactly. The main transmission route is parenteral. While it's not totally clear if saliva is a significant vehicle, the sources mentioned at least one report of HDV transmission in dentistry in the U.S., involving both dentists and patients. But given its absolute reliance on HBV, the conclusion is straightforward. All infection control measures for HBV also apply to HDV. If a dental practice has solid HBV precautions in place, vaccination, universal precautions, they are inherently protected against HDV transmission as well.
Okay, we've thoroughly covered the big five, A, B, C, D, and E, but our sources briefly mentioned a couple of others. Let's quickly touch on hepatitis G virus, HGV. What's the story there?
Right, HGV is an RNA virus, part of the flavivirus family like HDV. It's also transmitted through contaminated blood or blood products, so similar routes to HDV and HPV. It's found relatively commonly among injecting drug users and patients with hemophilia, again pointing to bloodborne spread.
Does it cause serious liver disease?
That's the interesting part. Its actual role in causing hepatitis is yet to be clearly defined. Many people infected with HGV don't seem to mount a strong immune response, and infections are often asymptomatic, without the typical jaundice or severe liver inflammation seen with other hepatitis viruses. It can lead to chronic viremia, meaning the virus hangs around in the blood, but its link to significant liver damage is still uncertain.
How's it diagnosed? And any dental concerns?
Diagnosis is usually by detecting its RNA genome using RT-PCR. Immunoassays can sometimes detect antibodies, anti-HGV, associated with recovery. In terms of dental implications, HGV RNA has been found in saliva, but whether it can actually be transmitted this way has not been determined to be a significant risk. Overall, it's not considered to pose a major risk of cross-infection in dentistry, and standard infection control should be adequate. No vaccine exists for HGV.
Got it. And then there were TTV and SEN viruses mentioned. Sounds even newer.
Yeah, these are more recent discoveries. Transfusion-transmitted virus, TD, and the SEN viruses, specifically SEND and SENH, are non-enveloped, single-stranded DNA viruses that have been linked to some cases of post-transfusion hepatitis. What's intriguing about TTV is that studies show a surprisingly high prevalence of chronic viremia, even in apparently healthy people, suggesting many might carry it without any illness.
So, common, but maybe not harmful.
The clinical significance is still being worked out. They seem to be transmitted parenterally, but our sources specifically state that there is no information on their salivary carriage or transmission in dental settings. So for now, they are less well understood and have fewer direct known implications for dental practice compared to the A, B, C, D, E group.
Okay. So we've covered a lot of ground on the viruses themselves. Let's zoom out now and talk about the broader implications of all of these hepatitis viruses, specifically within dentistry. Our sources really stressed how vital microbiology knowledge is for dentists.
Absolutely crucial. A solid grounding in microbiology, both general medical and specific clinical oral microbiology, is fundamental to dental education. It's not just academic. It's essential for dentists to accurately diagnose oral infections, understand their potential link to systemic health, and develop appropriate treatment plans.
And it sounds like the arrival of HIV back in the 80s really forced a major shift in how dentistry approached infection control. A real wake-up call.
It was a massive catalyst, absolutely. The emergence of HIV/AIDS in the 1980s significantly increased the regimentation of infection control practices across all of healthcare, but especially in dentistry. Concerns about cross-infection through blood and contaminated instruments, which were always there to some extent, became incredibly heightened. It really pushed the profession to adopt much stricter, more universal precautions, transforming dental safety practices globally.
So it's not just about knowing the science, but about the practical application, the responsibility of the dental team.
Exactly. Dental practitioners need to be conversant with all aspects of infection control. That means not only knowing how to implement the measures, diligently sterilizing instruments, using barriers, etc., but also understanding why. They need to be able to educate their entire dental team, ensure everyone is following protocols, and importantly, be able to reassure patients and address any fears they might have about infection transmission in the dental setting. It's about leadership and building trust.
And the risk for the dental workers themselves, the DHCWs, it's real, isn't it? So many routine procedures involve potential blood exposure.
Oh, definitely. Think about common procedures: tooth extractions, root canals, endodontics, gum surgery, gingivectomy, deep cleaning, root planing, scaling, even flossing sometimes, certain types of injections, putting a knocked-out tooth back in. All of these can cause some level of bleeding or exposure to saliva mixed with blood.
Right.
This inherently makes bloodborne infections like hepatitis B and C and HIV significant occupational concerns for DHCWs. They are constantly working in an environment where potential exposure is part of the job.
Which brings us directly to standard infection control precautions, or SICPs. This seems to be the bedrock approach now. What's the core idea behind SICPs?
The fundamental principle is simple, but powerful. All patients should be treated as if they are potential carriers of infectious agents. It's a universal approach. It means you don't try to guess who might be infectious and who isn't. You apply the same high level of precautions to every single patient, every single time.
So no special treatment for someone known to have Hep C, for example.
Exactly. The beauty of SICPs is that if you're applying them correctly for everyone, then generally no additional infection control precautions should be necessary for patients known to be carriers of infections like hepatitis C or HIV. The standard set of precautions, hand hygiene, PPE, safe sharps handling, sterilization, is designed to prevent transmission of these common bloodborne pathogens regardless of the patient's known status. It simplifies things and ensures maximum safety.
Universal protection, not targeted suspicion. Makes sense. Are there any exceptions? Times when standard precautions aren't quite enough?
Yes, the sources do mention exceptions for special situations. This is usually when dealing with pathogens that spread differently, like through the air, via droplets, or very easily through direct contact, and where standard masks or gloves might not be sufficient. Think of highly contagious things like tuberculosis, maybe influenza during a pandemic, or certain multi-drug-resistant organisms like MRSA in some contexts. In those specific cases, additional transmission-based precautions might be needed on top of the standard ones.
Okay, so for the DHCWs themselves, what are the absolute key prevention strategies? How do they stay safe day in, day out?
Number one, without a doubt, is vaccination. It's the cornerstone. Recommended immunizations for dental personnel include hepatitis B, MMR, measles, mumps, rubella, varicella chickenpox, and Tdap, tetanus, diphtheria, pertussis booster. And as we've discussed, the sources specifically highlight that the hepatitis B vaccine in particular has made the danger of occupationally acquired HPV infection minimal. It's had a massive impact.
So vaccination first. What else?
Beyond vaccination, it's about consistent practice. Regular training on infection control protocols. Meticulous hand hygiene washing or using alcohol rubbed correctly and often. Consistent and correct use of personal protective equipment, PPE, gloves, masks, eye protection. Safe handling and disposal of needles and other sharp instruments to prevent injuries. And of course, thorough cleaning, disinfection, and sterilization of all dental instruments and equipment between patients. These practices done consistently are absolutely vital for minimizing transmission risks.
And it seems like dentists have a role that even extends beyond their own practice's safety, maybe educating patients more broadly.
Indeed. The sources mention that dentists also play a role in advising patients on maintaining good oral hygiene. This isn't just about preventing cavities. Good oral health can actually reduce the risk of bacteria getting into the bloodstream, which is particularly important for patients who might be at higher risk for conditions like infective endocarditis, a serious heart infection due to underlying heart issues. It shows how oral health is really connected to overall systemic health.
Wow. What a comprehensive tour. We've really covered the waterfront on hepatitis, haven't we? From just understanding that basic term, inflammation of the liver, all the way through the different viruses, A, B, C, D, E, and even G and the others, their sneaky ways of transmitting and causing disease, and then tying it all back to the crucial role of prevention, vaccination, and infection control, especially in a field like dentistry.
It's a complex world for sure,
Yeah.
but understanding those distinctions, how HAV and HEV differ from HBV and HCV, the unique dependency of HCV, it really does empower you, whether you're a patient or a healthcare provider. Knowing the risks, the stages, the modes of transmission, it's powerful information.
Absolutely. This knowledge isn't just for the doctors and dentists, it's really for everyone. These viruses impact public health globally in such profound ways, from those silent carriers we talked about, to the immense scientific challenges like developing that elusive HCV vaccine, being informed about how they spread, the symptoms, and especially how to prevent them, vaccination for HB, safe practices for all. That's a crucial tool for protecting yourself and your community.
Well said. Knowledge is prevention in many cases here.
And as we wrap up this deep dive, here's something to chew on. We've seen incredible scientific progress, like the HBV vaccine fundamentally changing occupational risk. Yet we still face these huge, persistent challenges, like creating a universal vaccine for a virus as widespread and adaptable as hepatitis C. This ongoing, really dynamic dance between our immune systems and these evolving viruses. What does it really tell us about our strategies for tackling these massive global health threats? And maybe more personally, what responsibilities does this knowledge give each of us when it comes to prevention and advocating for public health measures? Something to think about.
A really important question for all of us moving forward.
Indeed. Until next time on The Deep Dive, stay curious, stay informed.